My next part on this program today is to introduce to you someone that is very familiar to MU Extension, but certainly someone that has come on board with us over the last couple of years to do great work. Sarah Traub joined us after being in the counties, working out across regions for a number of years as one of our Extension specialists. Today, she serves as MU Extension's Director of Education and Impact. In this role, she helps lead our efforts to connect campus faculty and programs with Extension faculty in, again, those 114 counties in the city of St. Louis. She's also serves as a part of our Equity, Diversity, and Inclusion Council and many other duties as assigned, as I'm sure she'll tell you if she had the opportunity to visit with you about that. So without further ado, it's my pleasure to present to you your next person that you'll hear from today, Sarah Traub.
Thank you, Marshall. Our first presentations this morning address the most challenging issue as we look at the human and economic costs of the opioid crisis in Missouri. As you follow today's discussion, we hope you come away inspired by a most remarkable group of people involved in creating solutions to this affliction. I'd like to introduce John Stimmel, who will introduce this morning's panelists and moderate the discussion. Professor Stimmel is a distinguished professor in the Department of Strategic Communication in the MU School of Journalism and core faculty member of the Master of Public Health program, the MU School of Health Professions.
Thank you, and good morning. And welcome to the first in a two-part panel discussion titled The Opioid Epidemic, a Statewide Response. I'm John Stimmel, Professor of Strategic Communication at the University of Missouri School of Journalism. Today, we have gathered faculty from all four system institutions and community leaders from across the state of Missouri to provide updates and insight into the nation's opioid crisis. Together, they'll discuss the current landscape in Missouri's urban and rural communities, explore the brain science behind addiction, and share how the system contributes expertise in this field, from spearheading national coalitions to forming small town partnerships. After each session, you'll have the opportunity to interact directly with our panelists in a series of breakout rooms, where they'll be available to answer your questions and continue the conversation. You can access these rooms through the Attendee Hub. Our first session is designed to set the foundation for this critical discussion. Let's meet our panelists. Dr. Brett Frohliger is the director of the Cognitive Neuroscience Core Faculty for the University of Missouri. Lisa Carter is the program director at UMKC's Collaborative to Advance Health Services and Technology Transfer Specialist for the HHS Region 7 Opioid Response Network. Dr. Rachel Winograd is an associate professor in UMSL's Department of Psychological Sciences and the Missouri Institute of Mental Health. And Dr. Claire Cuney is an assistant professor of psychological science at Missouri S&T. Thank you all for joining us today. Our first question is for Lisa. Lisa, we have a large audience with us today, and they bring with them a wide range of understanding on this topic. Can you start us off by providing a fundamental definition of what an opioid is, what they are used for, and how they differ from other drugs?
Sure. Thank you, John. Good morning, everyone. So you hear a lot of terms when it comes to defining what opioids are or referring to them. You hear things like narcotics, illicit substances, and then, of course, some of the individual opioid substances themselves. But actually, for purposes of research and kind of the current terminology, is that opioid is an umbrella term. So opioids includes the naturally occurring opiates, such as the poppy plant and the drug morphine. But it also includes the semi-synthetic or the synthetic man-made drugs, such as hydrocodone and fentanyl. Some of the other opioid drugs that people are familiar with and are prescribed, codeine, heroin, oxycodone, oxymorphone, buprenorphine, and methadone. So these are all different types of opioids. So the classification of drug captures all the opioids. This would be the legal prescription, such as the codeine, and also illegal substances like heroin. Although a drug like fentanyl is getting a lot of exposure now, is legal, it is extremely powerful and was meant only to be used for chronic advanced pain, such as those in cancer patients. One of the issues that we're having with fentanyl right now is that it is being produced and distributed illegally. Opioids do serve a purpose when used appropriately, and that is to primarily treat chronic pain. Morphine was widely used during the Civil War for injuries. By 1914, they were made only available by a prescription. Prescription opioids are generally safe when taken for a short time as directed by a medical provider. But because they produce euphoria in addition to pain relief, they can be misused and have addictive potential. Opioids bind to and activate opioid receptors on the cells located in many areas of the brain, spinal cord, and other organs in the body, especially those involved with feelings of pain and pleasure. When the opioids attach to these receptors, they block pain signals sent from the brain to the body and release large amounts of dopamine, or our body's natural feel-good chemical, throughout the body. And this release can strongly reinforce the act of taking the drug, making the user want to repeat the experience. Opioids tend to have a relaxing, depressant effect on the nervous system. Equally problematic is the fact that withdrawal from opioids can be extremely uncomfortable and painful, and this can lead people to continue to use and acquire the drug, sometimes using drastic measures to do so, with very serious consequences. So the stimulant drugs, on the other hand, differ in that they tend to speed up the body, speed the heart rate up, speed up breathing, increase appetite, increase arousal. So that's kind of the main difference between the opioids and some of the other stimulant drugs like the amphetamines or the methamphetamines, cocaine, and those kinds of drugs. They have a completely opposite effect on the body. So I won't say much more about the effects on the body yet because I know we're going to get further into that. Thank you.
Thank you, Lisa. I do have one follow-up. In the late 90s, pharmaceutical companies heralded these use of opioids as a critical tool for the medical community for patient care. What happened to get us to where we are today? For context, in 2017, the US Department of Health and Human Services officially declared a public health emergency regarding opioid use. In 2019, they estimated that over 10 million Americans misused prescription opioids. Nearly 3 million Americans were using methamphetamine or heroin. Very sobering numbers, made all the more pressing when we realized that over 70,000 people died from a drug overdose this year.
Yeah, so that's a loaded question. We could probably spend all day talking about how did we get to where we are today with the use of opioids. You know, you can look at it from several perspectives, that just simply the effects on the brain and the body that I briefly described. You can talk about the social context of use that has evolved over time. There's a lot of different perspectives. It's not easy to summarize quickly, but I'll try to give a broad overview. It has been said that what started the epidemic really was the belief in the 1990s that opioid pain relievers were safe and patients were not at risk for becoming addicted. The message was given to the public and medical providers by the owners of companies like Purdue Pharma, which made a lot of money selling OxyContin in the late 1990s. If you want to hear more about that, I was given some resources from a colleague Friday night. There's a book called Empire of Pain, written by a journalist, Patrick Radden Keefe. I'm not touting it as a factual historical document, but it is very interesting. There's also a podcast that was made as a result on NPR, and it's titled The Secret History of the Sackler Family. I listened to it last night, and it's just very interesting. So because it was felt to be safe, it was widely prescribed and highly sought after by patients who were experiencing pain. Then at one point, opioids were not just administered in emergency rooms in hospitals through IV. It became available through a pill, and then patients were sent home with it in the pill form and prescribed it in pill form. This led to the misuse of prescription opioids, both intentionally and unintentionally. What emerged was the overprescribing of opioids, and oftentimes other means of treating patient pain weren't identified or pursued. Of course, the drug found its way to the friends and family of the patients through sharing, and people began taking it for non-medical reasons. The survey on drug use and health collects information from people on the reasons that they misuse prescription drugs. In 2015, 11.5 million people, adults, provided information on their use and misuse of prescription pain relievers. And the results showed that over 60% of them were taking them to relieve physical pain, but it didn't always mean that they were taking them as prescribed. About 11% So they took it to feel good or get a high or relax and relieve tension. This points to the tendency we have as a species and a culture for immediate gratification. No one wants to be in pain or suffer in a prolonged manner. Most recently, we've seen an increase in use, misuse, overdoses, and death since the onset of the pandemic. So as I said, it is more complicated than what I've shared in its extremely broad overview.
Thank you. Dr. Froeliger, I'd like to turn to you now. There has been a shift in the public perception of addiction. A large part of that is owed to discoveries in the neurosciences behind addiction. What is it about our brains that make us susceptible to addiction?
Well, good morning. Thanks, John. So, I think that neuroscience really has been played a transformative role in how it is that we perceive addiction. And it's really helped us pivot our conversation away from this idea that drug addiction is perhaps deficits in willpower, or it's reflecting some weak constitution. What we've learned through neuroscience research is that just like any other disease state, such as diabetes or high cholesterol level or high blood pressure that could affect us, affect our heart and our central nervous system and our physiology, drugs of abuse can do a similar thing in our brain. And so what we've learned largely is, and Lisa had commented on this briefly, which is, whether it's opioids or nicotine or cocaine or methamphetamines, all these drugs are different. But one thing that's common is that when a person uses these drugs, it increases dopamine in the brain. And so we know that increases in dopamine that's a reward signal. So people initially may use drugs because they feel good. They make you feel perhaps less pain. But over a long period of time, that can disrupt many things. One is that in addition to reward, dopamine is a learning signal. So we learn the relevance of information when dopamine is released. So neuroscience has showed us that drugs become a rewarding thing among people who take them short term. And people learn a lot of associations that these drugs are going to produce a reward. Even after a long-term use, people report not feeling a great deal of reward from taking drugs. They actually will say that they feel worse. But in addition to dopamine, all these drugs of abuse, including opioids, basically modifies a number of neurotransmitters in the brain and circuits in the brain that are involved in just inhibiting a response, your behavior, where your attention is focused, learning and memory. So there is a saying in the neuroscience literature and community that drugs hijack your brain. And there's a lot of evidence that what they do is they modify the way our brain functions long after having taken the drug, and that those modifications make it extraordinarily difficult for people to quit using the drug despite the fact that they no longer may want to use them.
That's really interesting. But I'd actually like to talk to you about another portion of your research where you've been building on these foundational understandings to develop treatments for those suffering from addiction. What can you share with us about that?
Yeah, thank you for that question. As I had mentioned, how it is that people could use opioids or cocaine or methamphetamines or other drugs of abuse, perhaps short-term to feel better. But over long-term use, people oftentimes report that there's a diminishing return in the feel-good aspect of taking that drug, and it causes problems, right? So one of the things that we're looking at in my lab and other labs as well is, well, how is it that we can help people and provide them with environmental resources and resources to really refocus their attention on the things that make them feel good outside of the context of a drug. So a lot of social support. We have data showing that social support is really helpful. Behavioral therapy platforms are extraordinarily helpful. And one area within the behavioral therapy platform that we've found some robust effects, and in particular among chronic pain patients that have developed opioid use disorder, is mindfulness strategies and positive psychology and techniques from cognitive behavioral therapy. They teach people, how do you reframe what's meaningful in your life? how do you interpret and be mindfully aware of the things in your life that perhaps you would miss on a daily basis, such as a beautiful sunset or the pleasurable feeling of being around the people you love or friends and colleagues, to really focus attention on that and to help individuals learn how to better reappraise and manage their feelings of craving and their urges to take drugs, despite the fact that they've experienced diminishing return on how rewarding those drugs are.
Thank you. Dr. Winograd, this next question is for you. In a recent presentation, you stated that the term opioid crisis might be a bit of a mislabeling. You said that the term overdose or poisoning crisis is much more accurate description of what we're experiencing today. Why is that, and why does that matter?
Thanks, John. That's a great question. Yeah, I think we need to retire the term opioid crisis because when we use language, it impacts the way we think, and that impacts the policies that we enact to address the issue. So when we say the term opioid crisis, we tend to think of prescription opioids. We tend to think of an orange pill bottle. And though Lisa walked us through why that was really important at the beginning of the crisis, at this point, we're way past that. Very few deaths in our state are attributable to prescription opioids. And when we say the term opioid crisis, we think of these prescription opioids, and then we make policies that focus on reducing the supply of prescription opioids. At this point, however, the vast majority of drug-involved deaths in our state involve illicitly made fentanyl, which, yes, is an opioid, but it's completely different in terms of how it comes about, how it's created on the illicit market, the drug trafficking trade, how it's distributed. And more importantly, it's about way more than opioids. Opioids are, the majority are involved in the majority of deaths in Missouri, about 73% actually, but an almost equal percentage of deaths involve more than one type of drug. So the majority of people who have a drug-involved death have something else in their system other than opioids. So the fact of the matter is it's just way more complicated. We have a rising stimulant crisis. Fentanyl is absolutely dominating our drug supply. People are using drugs for all sorts of reasons and dying for all sorts of reasons. And when we use a term like opioid crisis, it makes us focus on the drug itself. And that is distracting, actually, because at this point, we have policies, we have systems, we have human beings that are absolutely contributing to the increased rate of death that we're seeing in our state. And we need to attend to these systems and policies and treatments and evidence and supports and resources, as Brett was highlighting. And to do that, we need to act with urgency that I think is elicited more effectively by a term like poisoning crisis or overdose crisis, because that's really what it is. It's not the opioid's fault. And that's not it's not the opioid pills that we need to eliminate from this earth. It's overdose that's preventable and that we can effectively eliminate with the right policies and systems and structured supports for people who use drugs.
Thank you. So you just talked about the urgency. We've been talking kind of in general, more about the nation. I'd like to zoom in a bit more about Missouri. Can you share information on who this is affecting the most? Is it affecting all demographics and regions of the state equally?
Yeah, that's another good question, and it's shifted over time. So sadly, in 2020, which was last year and the most recent year that we have complete death information for, we lost 1,842 Missourians to a drug-involved death. The majority of those are overdoses, but again, not the entirety, and the majority involve opioids, but again, not the entirety. But it hasn't affected us all equally in terms of death. In fact, the most significant disparity that we see is along racial lines. Black people in Missouri are more than 3 times as likely to die than white people in Missouri from overdose. That doesn't mean that more Black people are dying because that's a factor of our population and our base rate. We do have more white people in Missouri. But if you look at a specific population like Black Missourians, you're the rate of death is 3 times as high among Black people than white people. And so that suggests, yes, absolutely a disproportionate and disparate impact. Along those lines, the St. Louis region is the epicenter of the overdose crisis in our state. I just mentioned we had over 1,800 deaths last year. More than 1,000 were just in the St. Louis area. So a death is a death is a death, and it's tragic no matter who it is or what the circumstances. But if you're trying to focus on where is the area of greatest need, where are we seeing people most disproportionately impacted by this crisis, it's among Black people in the St. Louis area. And in fact, Missouri as a state, the last time these stats were updated in 2019, Missouri was ranked second in the nation for the rate of death among Black people. And St. Louis City specifically rated highest in the nation for rate of death among Black men. So, when we're making our policy decisions, when we're making our funding decisions, when we're doing research, when we're engaging community partners, it's really important to have people with different skin colors at the table. This is an esteemed panel, but we'd be remiss not to acknowledge that we look around, we have white faces in these squares. And so that's a suggestion to us that we need to be engaging more people with different perspectives and different lived experiences to contribute to this conversation.
Thank you. That is a great point. I do want to add to everyone who's watching, please remember that you can put your questions for the panelists in the Q&A feature of the attendee hub. So I'd like to move on now and shift our conversation a bit to start talking about the system's role in this work. Dr. Cuny, let's start with you. You recently championed a partnership with Phelps Health to help the hospital better understand its role in addressing the community's opioid problems. Can you share a little bit with us about that project?
Yeah, John, absolutely. So thank you so much for having me here today. So this project with Phelps Health is really a service learning and education research project that we initiated, and it's partly funded by Missouri S&T. And the purpose of this project is that it's really hard to engage in a very thorough educational opportunity with a community organization in just a single semester. So in partnership with another faculty member here at S&T, we've created a year-long practicum project over the course of 3 semesters, spring, summer, fall, to really more deeply address an issue. And this year, the particular issue was opioid crisis in the community. And so for the first third of the project, the students work with the organization to diagnose. So in this case, they did a community survey gathering perceptions about what the opioid crisis looks like in the Phelps Health catchment area, which is Phelps County and 5 contingent counties connected to it. Then in the summer, students worked with the organization to develop a change management plan on how they could implement a community education outreach program, and as well as what internal systems would they have to change, or what internal resources would they have to contribute to support such a community education campaign. And then now in the fall, the students are working with Phelps to implement that campaign and then do an initial evaluation process of it. And so we've gathered community perceptions to get a sense of, for example, how many in our community have been exposed to or are aware of the crisis, what their perceptions are of how critical this is, as well as what they think the healthcare system, specifically the hospital's role is in engaging with this crisis. And as we'll talk a little bit more, and I'm sure Dr. Burton will talk later in the next panel, there's a lot of different organizations that try to support and help and provide services for people who have opioid addictions and things like that. So the hospital's kind of been in a unique place trying to figure out the best way it can contribute to the community in that sense. So some initiatives that they're working on are doing a local campaign through churches, schools, and a number of different organizations, first responders, things like that. And then internally, they're working on doing what's called a large group intervention to reorganize and retrain and get their own staff and professionals prepared to be able to address anyone who comes through the door, to answer questions related to opioid addiction, or address if someone comes, into the emergency room or into OBGYN or something like that, with an opioid issue. So we're working on internal trainings as well as external communication plans.
Sounds amazing. So as you kind of tipped it off, we are going to hear from Dr. Burton, the Director of Medical Research at Phelps Health, in our next session. So thank you for the promotion on that. But I wonder if you can give us a little bit of insight into the unique challenges that rural communities face when addressing opioids.
Yeah, absolutely. And I'm going to answer this from the perspective of an organizational psychologist rather than an expert on public health specifically. Because a lot of my work has been working with Phelps Health and understanding rural healthcare delivery challenges. So one of the biggest challenges that rural healthcare organizations face is staffing, recruitment, and retention, which then directly impacts how the access that patients have, the type of access to care that they have. When there's considerable retention, it means you're always having to find new people who have to then be trained and then, take on new skills, new knowledge, new responsibilities, things like that. There's also challenges of, we know that rural healthcare providers have really deep connections to their community. So a lot of times the people they serve are also their neighbors, or their kids are on soccer team together, or they go to church together. So it can be particularly challenging in rural healthcare because of the stigma, but also the sadness that comes with trying to work with people with an addiction and things like that. It can be really challenging, resulting in burnout, greater compassion fatigue, and emotional stress as well. And so with these, we have inconsistencies in access to care. We have inconsistencies in the expertise and training because of recruitment and retention issues in rural healthcare. And so then that creates community challenges. And on top of that, and probably Dr. Burton will address this a little bit more, is healthcare literacy and travel and access to care from the patient's perspective is really challenging in rural communities as well.
Thank you. So Lisa and Dr. Winograd, I'd like to get back to the two of you. In contrast to what we just heard from Dr. Cuny, you're both located in larger metropolitan communities that actually both straddle a state line. Can you share a bit of what that sense of place means to this work?
Go for it, Lisa.
Thanks, Rachel. So, when I think about this question, I actually have two perspectives on this. 20 years before coming to UMKC, I was a program manager for substance use disorder treatment facilities, including a methadone program. And, we've got being Kansas City on the Kansas side and Kansas City on the Missouri side, there can be issues in funding in that metro area. So you may have a Missouri resident that has Medicaid, for example, but Medicaid doesn't pay for methadone, so they have to come over to the Kansas side. So there's issues of funding on the side of treatment providers and the consumers that are wanting those services. And also, even though we are a metro area, there are still access to care issues. Some people aren't able to even travel 5 miles. They don't have transportation. They may not have a home. They may not have employment. So we see a lot of the same access problems in the metro area that we see in the rural areas. In the work that I do now at the collaborative, there are matters of legality that can prohibit our ability to utilize life-saving evidence-based practices for people that are using opioids to the degree that they might be endangering their life, particularly when it comes to the harm reduction methods. For example, in the state of Kansas, needles are considered drug paraphernalia. So if we wanted to distribute clean needles, let's say, knowing that they might be used to inject an opioid drug like heroin, we can't do that because that violates the Kansas drug paraphernalia law. So therefore, our state cannot do a safe needle exchange program, which is an evidence-based harm reduction method. Also, just kind of being in the Midwest, either on the Kansas or the Missouri side, our Midwest culture brings with it certain beliefs about harm reduction practices, and not all communities, not all providers are willing to embrace the harm reduction practices as of yet. In contrast, some of the coastal regions have already adopted them or implementing them, and they are saving lives. So like everything, sometimes things are a little bit slow to trickle into the Midwest. We're hoping that we're going to get there, though. We are making progress.
All right, I'll take this next. Thanks for the setup, Lisa. I appreciate Lisa highlighting the role of systems and funding, because there are really two ways to answer this question. If we're thinking about individuals who use drugs, the state line doesn't really matter. Like, drugs go back and forth, people go back and forth. You can be on one side, one state, 1 minute, and 15 minutes later on the other side of the river or the state boundary. So when it comes to people who use and sell drugs, it's kind of irrelevant. However, when it comes to helping those people or offering resources, it matters hugely. So yeah, whether a specific funding stream crosses state lines, like basically that doesn't happen practically ever. There are some, innovative teams and collaboratives. I know both on the Kansas City and St. Louis side that have done this like cross-state partnership to go for grants together so they can see people, no matter where they're from. But most of the time, it's like they may as well be across the world. It's totally two separate systems and structures that fund the services. And so it is not always the case by any means that you can receive help where you use. More likely, you have to receive help based on where you are from, which state you're a resident. So that absolutely causes a ton of access problems. And I'm glad Lisa also said that it's not that absolutely in urban areas, we still have access issues. It's tough. You don't ever want to set it up like a competition between rural areas and urban areas, because like both have totally expansive and valid access struggles. You can almost think of it as equifinality. Like, no matter where you're from or what the problem is, you still have access to care problems. And in rural areas, it's because there are very few and you have to travel far distances. And in urban areas, you might have more services available, but you also have so many more people. So you have a big bottleneck and people just can't get in. So when you put that on a state border where you have a lot of drug use and drug trade and not a lot of cross-state partnership, it creates quite a mess.
Thank you both. Lisa, I'd like to go back to you because in addition to your work in Kansas City, UMKC is the home to the coordinating office of the National Addiction Technology Transfer Center Network. Can you share with us a bit about that project?
Yeah, so to be the home for the National Coordinating Office is a feather in UMKC's cap. So through a SAMHSA grant that went out, UMKC in collaboration with the Collaborative to Advance Health Services applied for that grant to be the home of the National Coordinating Office. So the Addiction Technology Transfer Center National Coordinating Office provides leadership and support to the 10 individual addiction technology transfer centers that are across the nation. They're divided up into regions. So for example, the region that I represent is Kansas, Missouri, Iowa, and Nebraska. So we're not only the region's ATTC, the National Coordinating Center that organizes all of the ATTCs is housed at the Collaborative to Advance Health Services in the School of Nursing. So what we do is, is to oversee the specialized behavioral and primary healthcare workforces that are providing substance use disorder treatment and recovery and support services. Our main purpose is really to disseminate and help people implement best practices for substance use disorders. So some of our customers include, state authorities, medical providers, community groups, mental health treatment providers, just to name a few. We provide trainings, produce manuals and webinars on various topics surrounding substance use prevention, treatment, and recovery. We also work closely with our sister networks. There are now mental health technology transfer centers and prevention technology transfer centers. And then most recently, the network coordinating office will also collaborate with the newly established International Technology Transfer Center. The directors of the coordinating office at UMKC are Lori Crom and Dr. Holly Hagel. So some of the topic areas that the coordinating office might help pull together different ATTCs or some of the mental health technology centers or prevention. We have done a series on traumatic brain injury, along with SUD, which is substance use disorder, the effects of trauma and substance use disorder, pregnant and parenting families, and substance use disorder, as well as family health. So those are just some of the topic areas that we help coordinate across our entire network and now internationally. So there's a lot of work that's going on.
That's great. So, Dr. Cuny, our final question before heading to some of the questions that have come in and then going to the breakout rooms is for you. We've heard a lot about the work that we are doing across the state today. Can you share some personal insights about how the community partnerships system institutions has and our community engaged teaching, learning, and research positions in the system so uniquely in our work around this topic?
Yeah, John, thanks. Absolutely. So again, my experience with this is as an educator, instructor, and then to some extent researcher as well. So my biggest goal is not necessarily to reinvent the wheel. So when I think about how I can aid the community and where I stand within the system as a faculty member, I think, how can my expertise best serve the community? I have my expertise. I do my research. I try to publish and, prosper in my own field. But then I try to think, okay, well, what can I really give back? As an organizational psychologist, that means I can help organizations do better what they're doing in their own efforts to serve the community, which is how I've come into partnership with Phelps Health, because I have a specific interest and area focusing on healthcare professional work experiences and healthcare delivery. And then on top of that, I think, okay, through my research, I can help this organization do better and also learn a little bit about the healthcare professional work experience. But then I also think, how can I involve my students into these efforts and create these learning opportunities, which is where this year-long partnership of addressing the opioid epidemic within our local community came about. Thinking about how we can get our students involved at each step in each phase and have a really in-depth learning experience as well as professional experience as well. So I think, it's about being creative, but within reason. So I'm not going to, I try to caution and say, again, I'm not an opioid expert here necessarily, but as someone who I understand organizational psychology and I've specialized in healthcare delivery and healthcare worker experiences, that's how then I came in connection with the opioid project and these efforts. So be creative about where you fit within your system role as faculty, as staff, as whatever, but think, where does my expertise lie and how can I use that to better enhance the community? And if you're working with students, how can we utilize them as well to engage them in the process? And I know at all 4 campuses, there are faculty who do this across the board with their students and have service learning opportunities and things like that. So I'm just one example of what's occurring across all 4 systems. And then I also just wanted to point out, and this is a theme that's come up in a couple, Rachel mentioned this a few times in her answers, but also in the opening comments from Marshall this morning. And as an organizational psychologist, again, this is really important to me. System issues require system solutions. And that means that, opioid crisis, poisoning crisis, all of this, these are systemic problems that require more than just one local effort or one hospital or one campus or things to that effect. And so here, I think it's really important to remember that in order to address something as massive as overdosing, we really have to have systemic approaches. And I'm just one part, my faculty role is just one part. So how can we put all these puzzle pieces together is sort of the big picture here.
Thank you. All right, so amazing job. Love to hear all the information that was shared this morning, and we've got more. So now we're going to look at some of the questions that have come in to the chat. If we don't have an opportunity to answer your questions, don't worry. I encourage you to join our panelists for more information, conversation in their individual Zoom rooms, and you can access the link for those rooms via the attendee hub. Okay, so first question. What community-based approaches have been proven effective against the opioid overdose crisis? And free for all, so whoever wants to grab that one.
Yeah, I volunteered to take a stab at this. It's hard to answer because for all sorts of reasons. One reason is like we have different definitions of community-based. And people within community have a lot of different opinions about what we should do. So I myself I could spend this answer talking about like what not to do and missteps that people like myself have made in the past. But I think one misstep that's on my mind a lot now is saying like, oh, let's consult the community as like that is an actual thing. It requires time and relationships and conversation and really getting to know individuals who are seeing all different sides of this crisis. So some of the things, for example, that my team and I have tried to build up in the last few years at UMSL within the Missouri Institute of Mental Health is, yes, we are partnering with the state. We're very grateful to work with Department of Mental Health to help steward a lot of these opioid crisis funds. And it's one thing to kind of put out, like, this is an evidence-based model. For example, we came up with the medication first approach, which really encourages utilization of medications for addiction treatment like buprenorphine and methadone, which can reduce rate of death by up to 70%, and they're vastly underutilized. So yes, we have these medications, which are a really effective tool, and we can like force them out there, like with brute strength, to convince people, this is what you need to do. This is effective. Here's the data. Here's the evidence. But if we don't have that like really internal buy-in among a lot of like neighborhood coalitions and community champions and like trusted people in neighborhoods and in churches and in schools and in community centers, then our message falls on deaf ears. So stuff that we've been working on, for example, is hiring community champions as consultants to our grants. So we have over 24 now people who are all over Missouri who we pay through these grants to do trainings in their community, to help spread the word, to inform us about what we're up to. And we have found that is one way to help kind of reduce the system and community lack of communication. It helps connect those dots a bit better. Also, stuff we're working on locally in St. Louis is building a strong community advisory board, for example, among people with lived experience with drug use and addiction. It's absolutely critical that they're at the table, and their family members. They have a lot of input. They've lived it. They can contribute to this conversation. So I think I wouldn't say there's necessarily like a list of evidence-based community-driven practices on this quite yet. It's like more nuanced than that. I think the most important thing is everybody talking to each other and not assuming that we have the answers just because of what the research says, but actually talking with people who have lived it and live in these neighborhoods and seeing what makes the most sense to them.
Thank you. Well, we've actually got a question for Dr. Froliger. So let's see, here's the question. I've heard it said that you can never really stop being an addict. Is it that addiction changes our brain in a way that we can go back? Or is it that some of our brains are hardwired or predetermined to be vulnerable to addiction all along?
That's a great question and difficult to answer for so many reasons. So one is that I'll kind of start at the end of the question and work my way backwards. So why is it that some people become addicted to one drug and another person doesn't? Or why is it some people appear to get addicted to drugs much easier than others. We don't exactly know why, except for there's a number of factors, right? And the answer is complex. One of which is that some of us are more vulnerable biologically to become addicted to, say, a group of class of drugs than others. There's also a lot of social determinants that lend us vulnerable to even being exposed to drugs of abuse in the first place. So that's where it gets really complicated outside of the context of what's happening in our brain. We have some biological factors that lend us vulnerable. We have a lot of social factors that lend us vulnerable. And there's much more than that. But now the question, I guess, is that if you become addicted to drugs, can you ever return to normal? So the first thing is, I don't know exactly what normal would be. But I think, most importantly is that if you look at what is addiction at some level, is that when you're using something which is going to disrupt your life, it disrupts your behavior, it disrupts your body, your brain, your relationships, your work, your school, your really social function, right? So can you stop engaging in the drug use pattern that's disruptive in your overall life? Yes, we know people can do that. And we know that there's a lot of effective first-line medications that have been talked about today by Rachel and Lisa, and approaches that Claire have talked about that can help people return to a healthier and more normal life. But as far as does the brain go back to a state at which it was at? No, none of our brains go back. And that's not just for addiction. We're all on some developmental trajectory. And when that trajectory changes, and then we do something else that changes it again, it may alter and twist, and it's new. But I think so to answer the question is, we never go back to what it once was, but we can definitely change our behavior and modify our brain function in a way to where we can lead healthy, productive, fulfilling lives.
Dr. Froeliger, one quick follow-up with that. How do we create a substance that interacts only with pain receptors without interacting with dopamine receptors? Can we reverse engineer molecules that only interact with the brain pain?
Oh, that is tough. I don't know that we can. I mean, so when we talk about medications and we talk about drugs, we talk about something that works on an opioid receptor, works on maybe a glutamate receptor or a nicotinic receptor. But it doesn't matter if we're talking about a substance use or substance abuse, if we're talking about an Alzheimer's medication or treatment for Parkinson's or a neurodevelopmental disorder. There are no clean medications, right? So anything that we would give a person is going to have off-target effects that can affect multiple systems throughout our brain and throughout the rest of our body. It can affect our gut microbiome, which can then affect our brain. So there, to my knowledge, at least yet, unless like the next wave of CRISPR kind of gene editing techniques that can specifically target some kind of like a viral approach to modifying, like a receptor, a specific receptor in the brain, we're pretty far from anything like that. And what that would mean in a cascading of the neurobiology throughout the brain, I don't know what that would look like. The last thing I would say to this briefly is, we think about, say, opioids or cocaine or methamphetamines is primarily affecting a receptor type in the brain. But then that cascades to other receptors and then affects the brain. And just like the heart or the lungs, the brain is an organ, so it's integrated. So if we stimulate one receptor in the brain, we're affecting the whole organ. So I think that would be a tremendous challenge, at least where we are scientifically.
Thank you. Lisa, one question for you. What is the biggest area of misunderstanding among the general public about opioids and this crisis?
Well, I think Dr. Winograd touched on that a bit. It's kind of the targeting of opioids as the issue. They do serve a purpose. They do treat pain appropriately when used as prescribed. I think a lot of people, when we talk about the opioid crisis, maybe the general public has this stereotypical view or vision in their mind of, what, the Skid Row heroin addict with a needle in their arm. That's not necessarily an opioid user. People that have been prescribed opioids for pain can unintentionally become addicted to them. Also, there are people dying from fentanyl who are not opioid users. I have an acquaintance in Springfield, Missouri. 2 months ago, her daughter actually was taking methamphetamine. It was laced with fentanyl, and it killed her. She was not an opioid user. She was using amphetamines. So really, the crisis has to do with all of the different substances. People are prescribed opioids appropriately. They can misuse them intentionally. They can become addicted to them unintentionally. And we have a saying in treatment, addiction does not discriminate against anyone. And so anyone using an opioid, and it can be anyone on this panel, or it can be the person that you see on the streets, and seen footage of some of the neighborhoods in California. Those do exist. But that is not representative of what we're saying when we talk about an opioid crisis.
Thank you, Lisa. We did have one other question about the Phelps County being awarded Rural Communities Opioid Response Program grants. However, we're going to save that for the next panel and have Dr. Casey Burton answer that one. So everyone just needs to stick around for the next panel. All right, so that is the end of our Q&A period. I would like to encourage everybody to join a breakout room and get some more time with these wonderful experts. Do remember to return for the second session at 10:30 and do the rest of the events throughout the rest of this week. We've got a great week set up. I'd like to thank all of you for attending. I'd like to thank all of our panelists. Wonderful work. And look forward to seeing everybody in the next session. Thank you.